I'm Deborah Gonzalez. I'm a feeding therapist. I'm a speech-language pathologist by trade. I've been working for 29 years, and I've been doing feeding for about 16 years. So I love working with pediatrics. I also work with adults. I love working in the medical field, and because to me it's always a mystery. I'm always trying to diagnose, what's causing this and how can we fix it. I love working with families, specifically with feeding. Every parent, you feel like that's the innate thing. If I can't feed my child, what am I doing? And so I know it's a very high stress level for parents. And so if I can help them feel more confident around their child, some children really can't learn to eat. I'm there to help the parent understand that and come to terms with that and still feel that they're, providing love in a safe environment for their child, etc. Some babies are, especially if they're premature, if they're really premature, they're not intended to eat by mouth yet, but at some point they need to learn. And so in many neonatal intensive care units, there is a development therapist or development specialist. Sometimes is a speech therapist or a OT, sometimes it's a PT, but they work with the nursing staff to help the child learn how to eat by mouth. But you can have problems from day one, whether it's structural, and we can talk now about, who needs feeding therapy. Sometimes there's a structural problem, cleft palate, or a recessed jaw, or a child doesn't know how to suck. Maybe a child with Down syndrome just doesn't have that reflex. So we need to work on matching the food to what the mouth can do and what the body can do. Or if a child has a tone disorder, let's say cerebral palsy or something like that, it's matching what is safe for them to take by mouth with what they're taking. Feeding then goes from being reflexive to learned. And when I say learned, I mean you can have a 4-month-old baby refuse to take the nipple because they've been experiencing reflux since they were born. And they've figured out that you put that nipple in my mouth, my tummy hurts and I throw up. At 2 months old, they can't say no. It's a reflex. You stick the bottle in their mouth and they suck. And then they cry and then they vomit. By 4 months old, they see that nipple coming and they gag and they say no thank you. So you can really start working with the family early on. Again, sometimes identifying what is the problem and advocating for them to get that fixed. So sometimes the question is, well, are they just a picky eater, or is there more to it? Do they need feeding therapy? And there is, and I have to give credit to Dr. Kay Toomey, who's a psychologist who developed a program called SOS, which is Sequenced Oral Sensory Approach to Feeding. But she has a great thing, and it's free on the website. It's picky eaters versus problem feeders. Picky eaters have a decreased range or variety of foods. Maybe they have 30 or more foods within that range. But a problem feeder usually has less than 20 foods. And this is probably in here too. If they drop it, they don't replace it. Here's the biggest one, I think. A picky eater can tolerate new foods on their plate. They might be able to touch them or even taste them. When you say, here, I'll give you a treat. If you just take one bite. A problem feeder is going to cry, scream, tantrum, fall apart, gag, vomit, whatever it is, when there's something new, something is different in front of them. A lot of what I try to recognize in the parent is the PTSD that they've already gone through, right? If I'm meeting them at 1.5 years, and I know that they were born at 30 weeks and they had surgeries, and the parent, and when they were in the NICU, they were always told to measure every milliliter of milk that child took because weight was like the #1 measure. And now, they're still, and again, as a parent, if you can't feed your child, what can you do, right? What's wrong with you? So probably the hardest part of my job is identifying what's really driving that parent. I think the families I've had the most success with are the parents or the families where they're okay with the fact that their child has a tube. Or I did have a family where their child was developmentally typical until 6 months and then had a brain tumor. And their goal was always to avoid having a feeding tube. So, okay, he's 3 and he still eats mushy food. He's 3, he's alive, right? So it's all brings what the parent, it's what the family's gone through, right? And I have to meet them at that level and recognize that and honor that. And sometimes, help them to grasp that they're here, look at all these other skills that they're able to do. I do have a lot of kids who don't necessarily make a lot of progress in feeding therapy, but they started walking or they started talking. And so I will celebrate that with the family just as much.